Hello, YouTube world. This is the first time I've gone live, and I think there are some people already here. I should have read an instruction manual or something like that before doing this, but you know, I'm the type that doesn't wait for the wind to be perfect before setting sail. I just kind of go. We'll kick off the actual presentation in a couple minutes, but I just wanted to make sure that I was in live before actually going. If you're here already, say hi in the chat. Let's see how this chat function works so I can try and pay attention to the engagement factor. Hello, Lori. Is this Lori from QUFW? Good. Okay. So you can hear me. So we're back and forth here. Excellent. Hello, Monica. I'll rely on some of my friends and colleagues to give me a call if we run into any technical glitches here over the course of the live. I've done about 1.5 million Zoom presentations, but not YouTube live. Thanks for joining. Live your fullest life. Oh, hello, Emmeline. Thank you. Yes, Alfred is coming, maybe landing tomorrow, I heard, on the ABC. Hello, Peter. As we have come to do with Zoom and our various online meeting platforms, we'll give a couple minutes before we actually kick off. Maybe around 9:03, we'll start the presentation. Oh, hey, Joe. Nice to hear from you. Thanks for sharing the link on the socials to get some of the ASOM crew out for the talk. So I'm hanging out in Frio, which for those that are unfamiliar, me yesterday, that's Fremantle, just in Western Australia, one of the suburbs of Perth. And yesterday I had an opportunity to go over to Bathurst Beach and watch one of the most beautiful sunsets ever in my whole life. So I was really happy to get to see that and be with Emmeline Lee here on this side of Australia, despite the terrible Cyclone Alfred that's happening in the south of Queensland and north of NSW. So yes, I echo Emmeline's comments that we are hoping everyone is safe on the east coast of Australia, getting to be where they need to be for safety, and hoping that it's not as bad as the forecast. Oh, hi, Renee. Thanks for recording this. I think it'll probably also end up living on YouTube as well, although, again, my first YouTube live, so we will see. And this is a bonus presentation, okay? So for the OGSIG meeting that was supposed to happen today, we were all supposed to be in the Gold Coast all together. The Obstetrics and Gynaecology special interest group in imaging had a fantastic lineup of speakers organized by Professor Emmeline Lee out of Perth here in Western Australia, and was going to bring together people from all over Australia and New Zealand. And sadly, the Cyclone Alfred has resulted in that changing to an on-demand fashion. So please stay tuned if you had registered for that meeting to the emails from the Encanta team, the fantastic team. Renee and Priscilla have been so accommodating and able to help me get out of the East Coast just in time yesterday before the weather really started to turn and things like the airports closed. And so this is a bonus talk and bonus bowel endometriosis talk. The other scheduled talks that I had on for today on adult endometriosis, adolescent endometriosis, and infertility, those will be coming to those of you that did register for that OGSIG meeting. And if you haven't registered, I don't know now that it's on demand if the organization will permit late registrations to access that on-demand content, but really, could be an interesting opportunity to get more education out there in that on-demand fashion. Though we are obviously so sad to not have the togetherness, the vibe of being in the same room, having an opportunity to engage, as obviously that brings such a uniqueness and flair to these meetings. But there will be more times. There will be more opportunities for that in the future, hopefully not thwarted by other once in 100-year cyclones like we have experienced in the last couple days and in the coming couple days. So I guess, we have a pretty good audience here already. I'm loving the engagement in the chat, although when I'm presenting, I'm definitely not going to be able to see that. I've never done a Q&A on YouTube. So from a housekeeping item standpoint, what I'll do is I'll do my presentation in a very traditional fashion. I'll share my screen, talk at all of you here. And then afterwards, I'll come back to the chat. So I'll try and scroll through some of those comments and do a little bit of an engagement that way, if that works for everyone. And other housekeeping items, I have to really thank Professor Emmeline Lee for being the brains and the coordinator behind this meeting, and then another meeting that's happening here in Western Australia next week, getting me out to Australia, which is absolutely one of my favorite places in the whole world, as many of you know. And thank you for being a great colleague and friend. Thank you to the OGSIG team, and to, again, always all the people who are enthusiastic about learning. For me, teaching about this topic is so important. The wave of endometriosis ultrasound that is happening is monumental, and we're just going to continue, and that is just going to help all of the people who we see in our clinical practices day to day with endometriosis in a way that we have yet to see in the world, and that's going to help with clinical outcomes. So this talk today is going to be a very small focus of endometriosis, but a really, really important focus of endometriosis. Again, I'm going to do my share screen. So if I have any technical glitches here, please don't hesitate to just ring me, Emmeline, because I'm not sure I'll be able to see the comments whilst I'm in share screen mode. Okay, and hopefully, if you see me and you see the content here, it's not too obstructing. I'm used to, with Zoom, the little icon of myself ending up on the side, but I think here maybe it covers. So forgive me with my technical glitches, and we'll improve with more YouTube lives in the future. So the topic of conversation today is there bowel endometriosis? And I'm going to teach you all about how we find bowel endometriosis very much from a pragmatic technical perspective, as well as what the nomenclature should be according to the IDEA consensus opinion. And so this is modern day bowel endometriosis with ultrasound. As usual, I have some disclosures here as I do lots of talks and have research affiliations. So that's my disclosure slide. And I thought, why not start this presentation straight away with one of the most beautiful bowel endometriosis clips of my collection. This is what I hope eventually all the people who are learning about bowel endometriosis will be able to achieve. It's not always this smooth and normal, of course, but the bowel is a very interesting structure for us to be able to identify sonographically through transvaginal ultrasound. We can see it incredibly clearly from an endometriosis lens. And I do think, and this is a seed to plant for some of our more general imaging experts and leaders of organizations such as Ranskar and ASAM, how much other bowel pathology can we see on transvaginal ultrasound as well? That's not the typical endometriosis gynecologic pathology. So this is a preview of what I hope by the end of this talk you will be able to do in your practice with a very clear set of steps that I will be putting out for you. Moreover, I need to really emphasize that from my perspective, as a gynecologic surgeon, before I became a sonologist, being exposed to surgical surprises, I had learned that ultrasound really is the way that we can be prepared for our surgical cases. Now, we can take it a step back and be prepared for talking to the patient as well in the clinical setting around what is their diagnosis and how severe is their diagnosis and which organs are affected and how will that impact on their symptoms and on their fertility. When we don't have clarity in the diagnosis part of the storyline for the patient, we cannot have clarity in the treatment part of the storyline for the patient. So for me, the diagnosis of endometriosis through imaging, the mapping of it in a very granular way, achieving clarity, has allowed for preparedness. So that way we can discuss with our patients this very complex disease in a more clear fashion. And that has had tremendous impacts on my rapport with my patients, on our clinical outcomes. And so I hope that this is not just about, learning a few skills to do nicer pictures in the office. This really does have a really impressive impact on the day-to-day practice for a gynecologist. If you are a gynecologist scanning, that's wonderful. If you're a sonographer, if you're a sonologist, if you're a radiologist, just know how much impact you can have on that patient's journey with their clinical team that's helping manage these symptoms. You really do have such an important role in achieving this preparedness. And when we talk specifically about surgery, no, not everybody is going to have surgery with endometriosis, and certainly not everybody is going to have bowel surgery when they have endometriosis. We do need to talk about why bad surgery is bad. What are the consequences of poorly prepared surgery? So, of course, the most obvious is that we have poor clinical outcomes for these patients. What does that mean? They don't have improvements in their typical pain symptoms or their gastrointestinal symptoms. They don't get pregnant if they are somebody who is seeking fertility. Sadly, lack of preparedness can lead to complications, and these can be complications that are clinical complications. So long-term, people can have things such as renal failure due to ureteral obstruction. But in surgery, we can unfortunately witness surgical complications that are actually predictable. When you know that the disease is bad, you can plan for that. If you don't know the disease is bad, if you have a poorly prepared surgical case, then you are going to end up with complications that are actually predictable. When this happens, when consequences of bad surgery, such as complications, happen, this leads to poor surgeon relationships. Of course, the most important is with the patients. They don't want you to have a complication on them when they're operating, when they're being operated on. But within the team, in the operating room, the operating theater, you have relationships with your nurses, you have relationships with your anesthesiologists, and that can lead to unfortunate reputations in the world of gynecology. And we do hear, it's very sadly, anecdotally, the high rate of complications in gynecologic surgeries compared to other surgical cases. You can also have bad relationships between the surgeons and the imaging team, because if you're not getting good imaging, you're not doing good surgery. And all in, this leads to decreased job satisfaction. And I do want to emphasize this as a very important point, because in most places in the world, our specialty is obstetrics and gynecology. And we are, for better or worse, trained to do both parts of this career. And if you do not have job satisfaction in the surgical side of gynecology, that will eventually lead to people stopping it. They will emphasize the obstetrics part of their practice. They will emphasize the office gynecology part of their practice. They will not want to do surgery. And we need gynecologic surgeons that are good surgeons, women and individuals who have endometriosis that are gender diverse. They need good surgeons. So we don't want to encourage people to move away from this. We want to encourage people that this is a great surgical specialty. And if you are prepared, you can do a great job. So how can ultrasound help us turn bad surgery to excellent surgery? And I bring it down to these two main points. The first is incomplete surgery is bad surgery. We want to be able to achieve complete surgery. That requires ultrasound mapping of endometriosis, going from incomplete excision of endometriosis to complete excision of endometriosis. Or in some instances, as again, not everyone will pursue bowel surgery when they have endometriosis, you take out all the intended endometriosis. It's very planned. The second comes back to that more patient-surgeon relationships and job satisfaction. Any time in life when we have a discrepancy between expectations and reality, this is not good. This leads to a lot of emotions. And so when we do good quality ultrasound, we can match the expectations and reality. That optimizes our preparedness. It optimizes the consent process. It decreases the complications. All in, ultrasound can take us from bad surgery to excellent surgery. Now, I always start these talks with a little bit of that philosophy because the audience is mixed. And I do know that the sonographers really do seek a lot more clinical information, relevance to the practice. And when they have opportunities to talk to patients, this information can really help build that rapport between the sonographer and the patient, as well as the imaging team that doesn't get to be in the operating room. This is really important for that knowledge. So now when we come more to the imaging, the actual diagnostic accuracy of the imaging, this is my most favorite paper that emphasizes the shift from the typical you can only diagnose endometriosis through laparoscopy, and laparoscopy is the gold standard to diagnose endometriosis kind of slogans that we hear online, to where we are now, which is where imaging has replaced laparoscopy for the majority of diagnosing endometriosis cases. This study by Goncalves and the team has shown us that when it comes to bowel endometriosis specifically, surgeons are bad diagnosticians. You cannot, in most cases, see bowel endometriosis with your eyes at surgery. The sensitivity, the ability to detect bowel endometriosis by a surgeon in this study was like 3 to 5%. Nearly all cases of bowel endometriosis were missed by the surgeons, and compared to ultrasound, which has an almost perfect diagnostic test accuracy from a sensitivity standpoint, meaning the ability to detect the disease, shows the very stark difference. And this really is what most of us in the world of gynecologic surgery do know, because we know that when we see a case like this, you get the diagnosis of endometriosis. That's not hard. you don't get the diagnosis of bowel endometriosis. This case is a very severe case, very clear-cut stage 4 endometriosis, the most severe form of endometriosis in the pelvis. There are, of course, nuances to that statement, including things like parametrial endo and sacral nerve root. But in any case, from a more typical endometriosis perspective, this really is the most complex situation. So it's not hard to get the diagnosis here, but what's hard is the mapping of this disease. No surgeon can tell you what's under the surface. I can guess there's probably bowel endo, there's probably uterosacral ligament endo, probably sidewall endo, but I don't know. You can't tell from this picture. So the diagnostic accuracy of a surgeon for bowel endometriosis is very low. And if you're surgeons, or if you are a surgeon and you say you don't need ultrasound, you don't need an MRI before these cases, if you hear that amongst your community, then we need to check our egos here. Surgeons cannot map endometriosis in this case. And the only way forward for endometriosis in these particular scenarios is with preoperative diagnostic imaging. Otherwise, you are not a good surgeon. That's just the truth. And so what might that look like when you look under the surface? This is exactly what it might look like. You have a very clear bowel endometriosis nodule here. And don't fret, I'm going to break down how to find these in the coming slides. But this is really clear. You can see this bowel endometriosis nodule, no troubles. And you can see the severe adhesions with this negative sliding sign that's also exhibited on this video. This is not hard to do. This is actually quite simple, quite straightforward to do, and it changes the game for endometriosis care. Here's another example. So just for the non-surgeons in the room, just for a little bit of a perspective here, we're actually so much further out of the pelvis than in that last picture, which was quite low in the pelvis. We have the uterus and the ovary down on the top right here, and the bottom right here, there's your ovary, that white structure. This very long structure that's kind of coming towards the top left of the picture is the bowel. And what we're seeing here is the sigmoid colon. And we have all these yellow fat pads. These are epiploica in the mesentery of the bowel. And so we are obviously trying to focus on this particular area, sort of center left here. There's a little bit of a whiteness, a little bit of concentration of a little tiny bit of a blue here. You know, this can catch somebody's eye, but it's pretty subtle, to be honest. And remember, most gynecologists are not trained to look at the bowel. Most gynecologists are general OBGYNs. So what's under the surface here? Well, we knew already from before this surgery what was under the surface. We had a very classic bowel endometriosis nodule here, and this is in the sigmoid colon, which is a lot higher than usual, but it looks the exact same. Hypoechoic nodule. This one is a classic nodule with a little bit of tapering on both ends. We knew that this was there. Coming back to that surgical picture on the left, you can really see that surface element right there. You can't see anything below the surface. But once we took this bowel endo out and we started to peel off of the serosa, these epiploica, which seem to be pulled inward to this region, you start to reveal that endometriosis much more clearly. And in fact, you can see that there's quite a length to it, which is what we already knew from the ultrasound. It's about 4 centimeters in length. And then when we cut that bowel segment longitudinally, which is something I do a lot in the surgeries as a teaching point for my team, you can almost appreciate that it has the exact same shape. It's a little bit kinked in the middle there. It has that same depth as the sonographic view. It's always this light bulb moment that when people see this for the first time goes to show how amazing ultrasound is at being able to see these lesions. So we were able to know what was under the surface thanks to the ultrasound. Now, when we come to the nomenclature, we have to refer back to the landmark paper from 2016 by Professor George Condis and Professor Stefano Guerrero, and a very large international team. The QR code is up on the left side there, which you can scan or take a screen capture or just Google IDEA endometriosis, and you'll get it. When it comes to the bowel, there are 4 sections to evaluate. There's the lower rectum, which is incredibly rare for endometriosis to impact. The upper rectum, number 2, which is the most common segment of bowel endometriosis. And then we have section 3, which is the rectosigmoid junction. This is where we start to reach the level of the uterine fundus. So 2, the upper rectum, is pretty much from the peritoneal reflection to almost the fundus, and then around the level of the fundus is where the rectosigmoid junction is, and the sigmoid itself is above that. And you can see in this image from the idea statement, it's almost out of frame, and that's quite true to the sonographic assessment of sigmoid because it is quite far above the peritoneal reflection, hard for us to see. When we do find a nodule, like all endometriosis nodules, we must measure it in 3 orthogonal planes. So our length, our depth, and our transverse. And here's a nice example from the idea consensus statement on those measurements in the bottom right. You're going to see a few more. It's really important to understand the bowel anatomy as well, and this is important for differentiating normal from abnormal, but also it really does help to look at this in a very detailed way because it will help you follow the bowel. So in this particular image here, we do have some free fluid to the left of the bowel. This is our peritoneal reflection. Our rectovaginal septum is just at the top of this image here. But from a bowel anatomy standpoint, this white surface area is the serosa of the bowel. And occasionally you can find superficial endometriosis just deposited on the surface there. But the most important for bowel endometriosis, the deep endometriosis, is the muscularis layer. And we have 2 layers. We have the outer longitudinal layer and the inner circular layer. And I remember those by the second letter in longitudinal and circular matching the first letter, outer, inner. And so that's a little trick to remember those 2 layers. And they are divided by this white line here. And this white line is something that can really help you understand the depth of infiltration of a bowel endometriosis nodule, as well from a surgical standpoint, whether the inner layer is affected has a lot of impact on our prediction of needing a disc excision, which would involve a hole, cutting an intentional hole into the bowel, which would then need to be sewn up. When endometriosis only affects the outer longitudinal layer, this may allow for what we call a shaving procedure, which is less invasive, less risky for the patient. Moving inwardly, we have the mucosa, which is this white line here. And then the lumen is the space that's potential space, so it's collapsed in the center here. And depending on the patient, you might find that there's content in there. This is a collapsed bowel with no bowel prep. My practice is not to use any bowel prep. I have never found that to be necessary to find bowel endometriosis with very high accuracy. And so I've just never integrated it into the practice. Not saying it's a wrong thing to do for those that have integrated it, but it is just an extra step and something that we've decided to not need. Now, I always want to show the non-surgeons in the room again. What does this look like? This is a normal bowel on the left, and this is a picture of the pelvis again surgically. And so just focus here, not on all the purple labels, but this yellow space here. This is around the region of the peritoneal reflection within the pouch of Douglas. This is with a pneumoperitoneum where we're expanding the entire abdominal cavity with gas. So this is not what it looks like at baseline. At baseline, everything is collapsed. But essentially, when you do stretch out everything, you can see the surface of the bowel here. This is the serosa, this sort of whiter, yellowish region within the center of that pouch of Douglas space. And so again, remember, surgically, we can only see the surface. We cannot see anything deep. So looking at them side by side, we can look at this bowel so much more detailed with an ultrasound. We can see all the layers. We can see the contents of the bowel. Surgeons, we only get to see the surface. When we come to that measurement, so as per idea, we should be measuring these in 3 orthogonal planes. And so when a lesion is relatively straight, I use the straight line to measure. When it is very curved, and you'll see an example of that, I use the trace function because we want to estimate the true length of the bowel endometriosis lesion, the true length of how much bowel is actually affected by this endometriosis invasion. And so this is what you should be capturing. I do try and capture images with and without the calipers, as it's nice for the quality of the picture, and great as well if you do teaching. So let's break it down now to the steps. Step 1, find the lower rectal muscularis at the anal verge. Step 2, follow the black line. Step 3, initially stay in the posterior vaginal fornix. And step 4, and a general guiding principle, if you get lost, restart or zoom out, get a global perspective. Now, these are the just the sort of the titles of the steps. Let's break it down a little bit more with some associated imaging. The first step is to find the lower rectal muscularis at the anal verge, lower using that idea terminology, right? And we want to physically aim the probe to the floor, and you want to go really slowly to do this. And I know that in some practices, we ask patients if they would like to insert the probe, which is a really nice thing to do for patient autonomy and control. However, when the patient inserts the probe, they usually insert it past the introitus and kind of all the way in very quickly. So you actually lose the entire lower rectum assessment, and you might lose the opportunity to follow the bowel with a nice momentum. So personally, I generally insert the probe in order to follow the bowel from this lower part. But if patients want to insert it, then of course they get to do that. And then you just retract the probe kind of back a little bit to that lower rectal muscularis anal verge region, and then you go from there. I just want to minimize how much I'm pulling that probe in and out. And I always start every endometriosis scan with the evaluation of the bowel, for the main reason that as you are inserting the probe, you can start to assess that lower rectum instantly. And if you start assessing the lower rectum and then you follow the line, coming to step 2 in a second, then you actually get the bowel done very, very quickly. And if there is bowel endometriosis, you get the sense instantly that this is a complex scan. So you then kind of get yourself set up for, all right, we're going to be doing an extensive mapping scan in this instance, versus finding it sort of later on in the scan. So here we're starting at the anal verge. You can see the vagina is splaying in the center. This is the anterior vagina. This is the posterior vagina. I'm kind of coming back and forth a little bit here to show how that vagina splays. But this on the top right of screen is your lower rectum, that muscularis layer. And so when you start the bowel evaluation, get your eye on that black line and do not take it off of that line. Immediately, you can start to assess that bowel. And as we are applying pressure coming past that introitus there, looking at this black line, you can see that anatomy is coming into play really nicely. Outer muscularis, white line, inner muscularis. The next step is to follow the black line. So like I said, do not take your eyes off the bowel. If you see things in the periphery, say hello and don't get distracted. Come back to the bowel. And I have sort of finally come to a description on how to follow the bowel, how to follow that black line with an actual like hand mechanics perspective. So essentially, you want the probe to be sagittal, no rotation, no rotating the probe when you're evaluating the bowel, unless you find a nodule. And then for your 3 measurements, you do got to rotate to transverse. And you want to do slow side-to-side movements with your hand, essentially 10 degrees side-to-side angles. And you're going to follow it like a snake-like structure. So let's look at this picture here, this little graphic, okay? I want you to think that you're looking down on the patient from the ceiling, an aerial view. The bowel is not a straight line. The bowel is twisty and turny, and it falls back on itself as it comes out of the pelvis. But if you think of it as this snake-like structure from an aerial view, and you start central, because the bowel is actually quite straight in the lower rectum region, and you reach the peritoneal reflection, the upper rectum, you're going to be constantly asking yourself, which direction is the bowel going? Left or right? Left or right? And when you do these 10-degree side-to-side movements, you can figure out, okay, it's going to the right. Then you ask yourself again, after a few more centimeters, as you ascend the bowel, are we going to the left or the right? Still going to the right. And it's kind of a constant questioning process. And so eventually you figure out the directionality of the bowel and you can follow it. And the earlier clip that you saw where you just could see me following the bowel so perfectly in one clip, that's what you can ultimately achieve. It is a little bit less jagged or rigidy because you're doing a little bit less movements because you can kind of follow that flow a little bit easier. But initially, slow side-to-side movements is key. The next step is to stay in the posterior vaginal fornix. And actually, this is one of the guiding principles for bowel endometriosis and deep endometriosis of the posterior compartment, period, full stop. You got to start in the PVF. And so for an anteverted uterus, the probe needs to move. You need to be behind the cervix. This is a move that you must master for endometriosis ultrasound. When you have a retroverted uterus, you have actually a much easier go because the probe is already in the position that you need it. However, even though you are going to start in the posterior vaginal fornix, you actually will need to bring the probe out if in the anteverted uterus fashion scenario, because you need to see the bowel higher up and you can only get so far in that PVF. The pressure application will start to get quite uncomfortable for the patient, and you also can't quite see so far away from you. So you then move the probe back to the anterior vaginal fornix to follow at the rectosigmoid and the sigmoid colon. And in the retroverted uterus, you obviously can't move to the anterior fornix, and so you just do your best to follow through the uterus in front of the uterus. And as you are following it, your hand is going from that pointing to the ground, which was step one, aim towards the floor, to much more level with the floor. You're kind of dropping your hand or raising the tip of the probe to look higher up in the body. And you're doing that at the same time as the 10-degree side-to-side movements. And so this is what it will ultimately look like. So we're going side to side to follow this bowel muscularis. And at the same time, if you watch this particular region, you can see the content is moving from left to right. So I'm actually doing as I say, I'm leveling out my hand. My hand was initially pointing to the floor, and then it's starting to come down to a more parallel position with the floor and looking up in the body. And so it's a downward movement with your arm to become parallel and a side-to-side movement. No rotation needed. And don't get distracted. But if you get distracted, if you get lost, if there's so much gas, if there's lots of pathology, big endometriomas, don't fret. Restart is one way to really make sure you have evaluated the bowel without being overwhelmed by all of the things that can distract you. Or sometimes what you need to do is you need to take a step back and get the probe out of the posterior vaginal fornix, look at it, everything through the anterior, sometimes putting your penetration mode on, giving yourself a big view. This is the same principle for the surgeons in the audience here that we sometimes do when we're so zoomed in at a pathology and you're like, wait a second, where are we? Where are we going here? You need to pull that scope out. You need to look at things from a global perspective to reorient, and then you can kind of start again and find things. So let's look at a couple cases, specific cases. So here we're following this bowel. Let's follow this bowel here. And I'm doing, as I instruct, 10-degree side-to-side movements, trying to figure out where this bowel is going. So in this particular clip, you're getting a little segment on the left of screen and a little segment on the right of screen, but we got to find the connection between those. And so here we go with a little bit of side-to-side. We're figuring out, hey, where is this bowel going? And we're just figuring it out there. We've just straightened that whole line there. And look what we've come to on left of screen. We've come to this area of thickened muscularis, very classic lesion. you can see the difference between here and here. Normal to the right, where my cursor is, abnormal, thickened muscularis layer, where my cursor is now. And so if we were to look at this type of lesion with measurements attached to it and with more characterization, we can start to look at the various idea consensus statement characterizations of bowel endometriosis, which for as long as I've been a surgeon has not yet made such a difference, except for this particular type of characterization is the pulling sleeve sign. It's more of a triangulated bowel endometriosis lesion that quite minimally affects the length of the bowel. On the top right here, I know you can't see the number, but this only measures 3.5 millimeters of bowel length affected. And when we look at the top left image, we're trying to depict here that hyperechoic white line where we can see that the inner circular layer there is actually quite intact. And this is endometriosis that's more of the outer longitudinal layer. So we think in some of these cases, the pulling sleeve sign can help us manage this patient in a less invasive way. And so we're going to see the surgery case now. So first of all, we can see how complicated this pelvis is with a huge left endometrioma and a lot of adhesions. And so again, think of that study by Goncalves and team. Surgeons are very bad at diagnosing bowel endometriosis. We knew it was there, so we went and found it underneath here. This is that point the bowel is being pulled up. You can see that, again, that tenting, that triangular shape of the bowel kind of being tethered up into this region here. We knew it was there, so we were going to go find it straight away to make sure we could confirm the presence of it. And once we have done the entire normalization of anatomy and excised all other lesions, we come to that bowel endometriosis lesion. So here we have the serosa of the bowel at the bottom of the screen. What the graph on the top of the screen is holding is the actual endometriosis. And you can see as we're cutting through here, there's a little bit of bleeding as usual. Every tissue in the body has small vessels here. Some have big. And we're showing that the inner circular layer here is actually totally intact. So there's no breach of the bowel lumen in this particular case. This is an excision of a bowel nodule involving the outer muscularis. And because obviously we're thinning that muscularis layer and we don't want a microperforation to occur or have major complications, we do ultimately put a suture essentially thickening up this outer layer, bringing in some of the lateral fat to protect the inner circular layer there so that we don't have a surgical complication. Here's another lesion that we're seeing here, which is a much more classic lesion. This is the typical comet sign that we see as per the idea consensus statement. We can see that it ends here. This is the more cephalad portion of it, and the caudal portion of the endometriosis lesion is top of screen there. We can appreciate that the uterus is here, and even though this is not showing the sliding sign or a dynamic mobility assessment, it is entirely adherent in that region. And even though this is a super zoomed in view, and so you kind of lose a little bit of perspective, you can see we have bottom right here some normal serosa with some normal apoploica, and then it kind of loops around and we come to this point right here. Very, very clearly there's endometriosis affecting the serosa, but you can't see below the surface. So we don't know that this is actually a very large, deep endometriosis nodule affecting the muscularis layer below this region in this particular area. So the ultrasound here was really instrumental in us planning the surgery correctly to involve ultimately what is a segmental resection of the bowel. So after the normalization of the anatomy again, excision of all of the other endometriosis lesions, we really mobilized the entire rectum, and we're putting the stapler just below the lesion here. Once we get a little bit of a clear view here, I'll pause to show you where the nodule is. So the stapler is below the level of the bowel endometriosis nodule. The bowel endometriosis nodule is in this region right here. I can tell you that with our eyes, even after we've done the dissection, we cannot see it. we can feel it, and we use the feel to help us understand the borders of the nodule in order to know where to put the stapler and where to do the upper resection as well. But you can't see it. So the ultrasound is fundamental for us to know that it's there confidently. And without it, I don't think many surgeons would be doing a segmental resection, because it's obviously a huge thing to cut out somebody's rectum. Here's another lesion. This is a very long lesion. So what you have to know is that sometimes there are multifocal lesions. Sometimes bowel lesions are very long. You sometimes can't capture them in one picture. And so you then have to either capture them in two side-by-side pictures to get a full length measurement, make sure a cine loop is captured to really identify that full length of this lesion. You can see how long during the cine loop that nodule, that thickening area is present, very long. This patient, if they pursue surgery and if they pursue bowel surgery, this is a guaranteed segmental bowel resection. Here we have at the beginning of that clip what we call the classic moose antler sign. You can see that jaggediness just in that region. And here we have a really unique type of lesion. I made reference to these lesions that are necessary to measure with the trace function. So we have essentially this lesion that's walled itself off. It's enclosed, whereby the shape of the bowel endometriosis is essentially a C, and the two ends of the bowel that are where the interface of the normal and the abnormal are, they're essentially stuck to each other. And so this type of lesion as well can go missed at surgery because it's closed itself off. And this type of lesion is the type of lesion that can result in a bowel obstruction. What you can see at the bottom of the screen on the right, just underneath the green overlay, is how narrow this lumen is. This is very narrow, and these patients are the most at risk for bowel obstruction. This patient of mine, I was really encouraging of surgery for her because I really thought that it would make a very big difference for her. She wanted to avoid surgery at all costs, and she wasn't having yet any concerns for obstruction. So she wanted to pursue medical management, and she's actually done very well with medical management, though I have been keeping a close eye on her and advised her that if she has any concerns for bowel obstruction, she needs to get on the phone to me instantly, because this is one of those emergency scenarios that we do see in endometriosis care. And as we come to the end of this, I just need to make reference to a couple studies, because there are FAQs, one of which is, do I measure the lesion to anal verge distance? And so as you'll notice, my name is here with Prof. Condis. We did this great work with Gernot Herdelis and Christine As-Eng from Europe, from Vienna, Norway, many years ago now. And this was something that we felt was very important. And knowing the distance of the bowel lesion to the anal verge is important. I don't actually measure it anymore because I'm able to determine, based on the localization of the upper rectum, rectus sigmoid, where that distance lies. So most upper rectal lesions are around 8 to 12 centimeters from the anal verge, meaning most are amenable to a classic low anterior resection if surgery is going to be pursued. Anything higher than that actually is much less risky from a surgical standpoint, from an anastomosis standpoint. So those higher up lesions are more reassuring, but I map mostly based on where the lesion is stuck. Is it stuck to the vagina? Is it stuck to the cervix? Is it stuck to the mid-uterus? Is it stuck to the fundus? Which region of the bowel is it? It's not a bad thing to measure. It's just a very finicky thing to do. If you do it, and you do it as instructed by this paper, then you know that it is accurate. We have studied this. And the other paper is the infiltration paper that came from the same team of individuals. So we do know that the diagnostic accuracy of ultrasound is very high for bowel endometriosis. The more granular nature of ultrasound to determine the depth of infiltration is accurate. So this is helpful for us to know that, you know, what we're talking about, what we're encouraging here is not just because we want to and we feel like we can, and it's anecdotal. This is evidence-based. And so just to conclude, from a surgical standpoint, one of the things that I really believe in is patient autonomy and patient control over their health. And so when we think about the scenarios that we face for deciding on surgery, we could dichotomize that to patients are exposed to advanced preoperative ultrasound imaging or they're not. And so with preoperative ultrasound, we can diagnose, we can inform them the presence of it, we can plan for excision of endometriosis. When there's bowel endometriosis, we can allow patients to decide, do we pursue bowel surgery for endometriosis or not? And if we do pursue it, which type of surgery are we going to do? This also helps us determine whether they are going to be admitted to hospital or not, how much time off they'll need, do we need our colorectal surgeons? Depending on the surgeon, the gynecologic surgeon, some do their own shavings and disc excision, that's myself. Very, very few do their own segmental bowel resections at this point in time. So this can help determine who needs to be in the operating room. That consent form is very detailed, very thoughtful. Without preoperative imaging, you might say, we're going to do excision of endometriosis, but you don't know what's going to happen when it comes to the bowel at the time of the surgery. And like I've shown you, surgeons are very bad at being able to know for sure that there is endometriosis in the bowel. So they might actually miss it altogether, meaning the patient never gets to be in control of that decision. But if they're going into that surgery without knowing it's there or not there, are they even really in control? Or are they just giving a blank check consent form to that surgeon, which I totally disagree with. And the nature of our hospitals are all very different. The nature of our health systems are all very different. Some people will say, hey, our colorectal surgeons are just next door. If we need them, we'll just call them. But they're not just next door in the tea room having a nice break. They're operating on somebody else. And so that day that they have planned is now going to be affected by you asking them for help. And that help could be 30 minutes or it could be 3 hours. So this culture of we'll just call them if we need them is also very bad and needs to move out of our health system. And it can. It's not just me saying this. It can. The ultrasound can allow us to know we need you to be there, dedicated to this patient in that surgery in that moment, not trying to balance everything going on in your life. So with all that, I'd like to thank you all for your time and your enthusiasm. I'm going to exit the share screen and see what's happening in the chat. I think I can exit yeah, there we go. So I can see you now. All righty. So how about I plan for maybe about 5 to 10 minutes of questions, if there is that much questions in the audience, and we'll kind of close around 10. So, and for all the people that said hello, hi, Ali, hi, Carlos, hi, Jackie, hi, Danny. Great to see you all. Thanks, Emmeline. Very nice comment. So obviously, in real life at the OGSIG, Emmeline or whoever was going to moderate the talk would be there and, asking for questions. Not in this case. Sorry, I don't think there's a way for you to be vocal, though we'd love to hear you, Emmeline. Please, if there's any questions, don't hesitate to enter them into the chat. I can see the chat. I can answer those questions. All right, I see. Okay, I think Jackie's got a question. If you find 2 or 3 separate lesions, is it helpful for surgeons to measure the distance between them? Absolutely. So as per the IDEA consensus statement, we should be looking for multifocal bowel endometriosis. That's number 1. And so if you find one bowel lesion, don't stop there. Keep ascending, keep following that bowel higher and higher until you can't see it anymore to make sure you're not. Sometimes that segmental resection is the preferred mechanism. And got a comment from Ali. Agree. Measuring to anal verge is a waste of time. Thank you for the bluntness. I think it complicates the scan, and we can probably guesstimate with the same accuracy as we can measure. Yeah. One thing that is very true for individuals like myself and Ali is we talk the talk, we say these very blunt things, but actually, we're gonna do a study on this, and we'll try to have our hypothesis and prove that hypothesis with research. So it's not just our feelings on things, but it is complicated to measure, and it is time consuming for sure. All right, we got a comment from Emmeline. Interesting discussion regarding anal verge to lesion distance routine for you guys. So maybe the more you do something, the easier it is, and not suggesting to stop doing it, but just knowing that for, I think, some of the surgical relevance, it seems to be not so helpful. Then maybe you can save some time. Next question from Emmeline. Do you measure depth of lesion specifically? Yeah, that's my second measurement. So it's length, depth, and width, and the transverse there. So that does matter in terms of how IDEA guides us and how we should measure all lesions. I'm not sure that it impacts on surgery that much. We haven't seen anything that suggests, a depth threshold that predicts which type of surgery somebody should be having or their symptoms. But we are still very much at the infancy of endometriosis imaging and the clinical matching of the patient to the imaging, the surgical outcomes. So I think it's a great question, and everything is on the table for us to evaluate. And then relationship to lumen. So less so the relationship to the lumen, more that which layer of the bowel is being affected from the muscularis layer. Is the inner layer being affected, or is it just the outer layer? All right, so I don't see any other questions. I'm happy if anybody's got any last questions, but also happy to end this YouTube live and get out into the sun. I'm sorry for the East Coast people who are having wind and rain and cyclone, but I'm going to get a little bit of sun. Thank you, everyone. Again, thank you, Emmeline, for getting me out to Australia. And there's another question. Jenna, last question. Where did you have your specialized training in endometriosis imaging? I had mine in Sydney. So my roots are Canadian from an OBGYN standpoint, but my endometriosis education is very much thanks to Professor George Condis at Nepean Blue Mountains Hospital at the University of Sydney, where I did my fellowship and my PhD in a combined surgery and ultrasound fellowship. And it has been a life-changing experience, both living in Australia, being with Australians, and learning all about this. So I'm very grateful to this country. Thank you, everyone. See you next time.